Today our guest is Dr. Mark Spohr. He's the Managing Director of Medical Informatics Incorporated since 1993. Dr. Spohr has also held positions such as Technical Officer at the World Health Organization and as a Senior Technical Officer at John Snow Incorporated, which is a public health research organization. Dr. Spohr earned his BS in Electrical Engineering at the University of Pennsylvania and a medical doctorate from the University of Cincinnati College of Medicine. And welcome, Dr. Spohr.
Well, it's good to be here. I'm happy to participate in this grand experiment here.
It is an experiment. Yes.
Well, we'll see.
Hello, Joycey. Welcome. If you got your webcam working, that'd be great. Okay, I do have, the format of the show is I'll have some questions for Dr. Spohr for about the first half, and then we'll open it up to panelists as well as anyone that may be watching the live stream on the website. There is a chat forum available on the website that you can enter questions or comments into, and we'll be monitoring that as well. So Dr. Spohr, if you would just tell us a little bit about yourself, where you're from, and how did you get from electrical engineering into medicine? And I don't want to act like that's really a strange thing, because I know a surprising number of physicians that came from the electrical and electronics engineering background. So I'm really curious, how does that happen?
Yeah, well, it's I'll give you the short version of my life, and I'm getting old now, so I'll have to go quickly through it. But starting in high school, I wanted to do biomedical engineering, and at the time, I thought that going through engineering school and then medical school would be a good way to approach that. So so that's what I did. I went to engineering school first, which was University of Pennsylvania Moore School of Electrical Engineering, which is the it was where the ENIAC, the first electronic digital computer, was built during World War II. And they still had pieces of it down in the basement. And then I went on to medical school. Of course, by that time, since I've been in electrical engineering, at that time, computer science was still a pretty small field. But it was clear that that was the way that things were going with the different electronic devices. After medical school, after I got out of medical school, just to support myself, I started doing emergency medicine work, and I worked for about 10 years in doing emergency rooms in the area. But during the time from, say, 1975 to 1985, I was working on developing early computer software. I developed a drug interactions program and some medical records programs, scheduling, patient scheduling, and then started working on patient billing programs. So I started a company called Pacific MedSoft in 1985 to sell electronic medical records and patient billing, insurance billing applications. I did that from, say, 1985 to 1992 or so, when I sold that company. At the time, I kind of I had some friends who were working in international public health, doing consulting on health planning, health policy, and they needed somebody who understood computers to help get at data. So I started working on with the WHO and the World Bank and Asian Development Bank on health information systems, and working first in Malaysia, Sri Lanka, Pakistan, similar places in South Asia, doing analyzing health data and working on health information systems. And so I worked through the 90s and into the new century, doing mostly independent consulting work. I did work for 1 year in Washington with John Snow, and they were primarily a contractor to USAID. And then I worked for 3 years in Geneva with WHO, and then finally reached the WHO mandatory retirement age of age 62. So now I'm back to doing independent consulting. But in the meantime, I've worked mostly in Africa, South Asia, Southeast Asia. Now I'm down in the South Pacific, working in the Solomon Islands. So,
Right. Okay. So
covered those areas. So that's how I don't know. That's how I get from one area to the other, I guess.
right. Right. I forgot to mention the members, the people in the Hangout. If you would please, if you're not speaking, mute your microphones, because it causes kind of this echo and feedback and everything. It helps a lot. Thanks, Luciana. And okay, the work that you've done, Dr. Spoor, a special interest to me, or what I find so most fascinating, is the fact that you have worked in so many places around the world. You have a real handle on how the differences in culture can affect information systems, especially when you talk about something as complex as healthcare. Can you tell us a little bit more about your work with the DHIS, what DHIS is, and this the various places that you've worked with this system?
Yeah, the DHIS is probably the premier system that's used to collect health information at the facility level, and primarily in developing countries, although there are some installations in developed countries also. It's designed as a health facility information system. I first came in contact with it in the, I guess it was about 98 or so. I became aware of it. It was developed first in South Africa under USAID, and then I got to see it close when we had the John Snow had the major evaluation meeting in South Africa, so I got to see it in action there and meet a bunch of the people who were involved with that. And it's an open source product that's gone through a lot of development and has been generously supported by several different aid agencies over the years. But the real benefit of it is that it's an open source project that has a very vital community, a very active community of support. So I've recommended it many times in my consulting work, and implemented it a few times myself, of course, along with other people who really know it better than I do. I mostly just know it well enough to say this is what you should use. We're currently going through an implementation now in the Solomon Islands, which is technologically challenging, but we finally have a good stable installation by installing it in a cloud server, which happens to be in California, which has good connections to, or as good as it gets, to the Solomon Islands.
What are the technological challenges then? Is it infrastructure in the Solomon Islands? That's interesting because you say you have a good connection to California, so.
Well, software as it's developed over the years has gone from mainframes with connected terminals, which are connected just locally, to software installed on individual PCs, which is extremely difficult to maintain and communicate. And now the current model is using the internet to connect software, and that's where the DHIS system has a big advantage. Even though it was designed maybe 15 years ago, they did use a web-based design for it, with a common database. Originally, it was local databases using Access, but they switched over to the stronger Postgre or MySQL databases,
Okay.
and used comment, used the full web interface. So the advantages of a web interface are is it gives you immediate communication of your information, and it gives you all of your information in a central database, so you don't need to go through problematic data synchronization, which is oftentimes very difficult. And you don't need to maintain software on different computers, which, when you have computers spread all over a country, is very difficult. So we put the software. We installed the software originally in the Solomon Islands on a server that was in the Ministry of Health, but it was a Windows-based server that didn't seem to agree with the full Postgre and Tomcat and Java server. Didn't seem to work well. Plus the level of skills at in the Solomon Islands to maintain the server was very weak, and it essentially boiled down to they had one person who knew how to do it, and then he decided to go on to the to better things, which unfortunately is what happens a lot in developing countries. Is you get some good technical people, they tend to leave and go into the private sector where the money's better.
Sure. So the problem then really was within the department or the Ministry of Health then not being able to support it locally.
Yes. So what we did was we finally recommended. We originally recommended they move to Linux locally, but nobody understood Linux locally, and nobody was willing to do that. So the cloud server was really the best solution, and this has been adopted by several other small countries also. The Solomon Islands only has 500,000 people, and they just don't have the resources and skills. So we've installed it in a cloud server, which happens to be in a data center in California, because when we check the connectivity from the Solomon Islands, that was the best place for the existing data centers. The Solomon Islands currently uses satellites for data connections, which gives you a fairly large lag time, like 600-700 milliseconds. But they are installing a fiber optic cable, which we hope will be operational within a year, which should greatly improve the bandwidth as well as the lag times. It's the nice thing about the DHIS software, it was designed for use in poorly connected environments where you have low bandwidth and oftentimes a lot of lag time with the satellite connections. And most of the work is done on the server, and you're just sending a small amount of text back and forth to each of the workstations. So this is crucial in making this operational in this type of environment. And that should only improve as their bandwidth improves.
Sure.
In addition to the main installation on Guadalcanal, which is the main island, they have 9 provinces, and they're spread out over thousands of square miles of ocean in the South Pacific. So the connectivity across those to each of the provincial headquarters is also problematic. But the amazing thing is it does work, which is good.
Well, that's great. That's great news. So this kind of gives us an information system for the aggregate information then at, say, a Ministry of Health level, or certainly at least a provincial level if they wanted to install it locally. But it sounds like that's a technological challenge there. What do you see the big the EMR in this space with NGOs and with the WHO itself that's up and coming as OpenMRS? Do you see increased connectivity between OpenMRS and DHIS? I know that is being talked about, but SDMX HD, which is, and let me go over some of these acronyms here. DHIS is, I forget. some
District Health Information.
district health information system. Thank you. And SDMX-HD is statistical data matrix or model exchange, metadata exchange.
Yeah,
Yeah, statistical data metadata exchange for the health domain, and this was adopted from SDMX-HD, or I'm sorry, from SDMX-8 to HD by the WHO a couple of years ago, 3 or 4 years ago, and OpenMRS is a Java-based open medical record system established by Regent Street Institute and supported by several NGOs. So now that we gave everybody kind of a background on that, do you see that there will be increased connectivity between OpenMRS, and so that the DHIS software may not have to have so much manual input?
Well, there's two fundamental types of software in the health domain, and we've talked, and we've just covered both types here. The DHIS collects aggregate facility information, which is usually reported on a monthly basis, but can be more frequent or less frequent. Whereas a software like the OpenMRS is an individual patient longitudinal medical record. And the data communication between the two is usually one way between the individual record systems, the individual electronic medical record, and the aggregate system. So you can collect aggregate data from the individual records and put that into the DHIS. I guess it should be noted that the DHIS also does have an individual patient module where you can track some individual patient information. It's not nearly as complete as the OpenMRS system, which is really a full-blown medical record system. But it does have some capability for that. The interoperability and data standards are something that's unfortunately, in everybody's rush to implement systems, that's kind of been neglected. And we were talking earlier about this. WHO finally had a meeting this week about data standards and interoperability. But this is something that really should have been taken up at least 5 years ago. When I went to WHO, it was the intention at that time was to establish a department of health informatics that would help promote things like these data standards and interoperability as well as tools. But it never really got off the ground. And if WHO has a role here, I think the role is in helping to establish the data standards and interoperability. There is connectivity using SDMX HD between OpenMRS and the DHIS, and I'm not that familiar with areas that with countries that have both of those things installed to know how much that is used, but there is the basic connectivity there, so that that can be done. But the key is, of course, having your metadata all using common standards, so that when you're speaking the same language, when you're talking to each other.
Right, and so since we're talking about standards, I found it interesting. I guess it was in 2010 when I went to this the Data Standardization and Interoperability Conference in Geneva, and SDMX HD was kind of coming up to version 1.0, I guess, something around there. And I gathered at that time that SDMX HD was useful to communicate between instances of DHIS, and not necessarily to others, but to other systems. But the chatter that I've heard on the OpenMRS list lately is that they're attempting to use SDMX HD. And I find this to be a bit confused and confusing. Do you have any insight into why WHO hasn't supported a interoperability standard that's already in existence, something like ISO 13606 or even HL7. Something like HL7 in the US, as you know, has a long history of communications standards capability.
Yeah, I think this is kind of a missed opportunity for WHO. That again, as I said before, I think this would be one of the primary functions of WHO, is in establishing standards and guidelines, and the establishing a data standard is something that would be crucial for WHO. These things tend to be driven by people, and unfortunately, the WHO does not have people who are strong in the area of health informatics. I mean, it sounds odd because WHO collects a lot of information and needs a lot of information, but they don't really have part of WHO which really looks at how you do that properly. It tends to be something where each individual program kind of does the best it can to collect its own data for its own program, whether it be HIV or tuberculosis or whatever. Again, when I went to WHO in 2007, the idea was then to establish a department that would do this, but that never got off the ground. And I think there was, unfortunately, the people there at the time were just not capable of getting that established. As far as which standard to use, Patrick Whitaker did a good job of bringing the SDMX HD into a usable form, but again, there wasn't a lot of institutional support for it. I think the HL7 is a good format, but the SDMX HD is a little bit more appropriate for the types of aggregate, which includes some aggregate information, whereas the HL7 is more oriented towards individual patient information.
Right.
Yeah, I'm not a standards geek, so I can't really speak at length about all of these, all of the fine points of them. But I hope something good came out of this recent conference in Geneva, since they seem to be making an effort along that area again. But I haven't seen any of the actual output of the conference. They haven't posted that. They just posted the agendas and so on, which kind of look like the standard stuff of, survey of what's going on, without any strong recommendations coming out as to specific standards.
Right. Well, I hold the same hope that you do. I know that in the past, my working since I first met you, I guess in 2007, there's always been a little bit of interest in the multi-level semantic interoperability frameworks such as OpenEHR, to some extent ISO 13606, and now I get to plug my own project, multi-level health information modeling project. These multi-level projects that can encapsulate more semantics into the interoperability layer. But specifically, I know that there's been some interest in the past, the WHO, about OpenEHR, and I know that some of the people that were at this meeting this week have at least somewhat supported OpenEHR, so we may see some movement in that direction. But I don't think that, from what I know about SDMX HD, and I'm not an expert on it, but I did work with it some, I think that it's a great idea. The problem is no one else in the world is going to use it. And that's the big problem when you're talking about something that's open source. And that I wanted to kind of bring this back around, because I want to ask you how much you feel like, and you did mention this earlier, how much you feel like being open source has helped DHIS succeed over all this long period of time like it has.
Well, yeah, I think the open source has certainly helped the DHIS. And in terms of the trying to apply that experience to standards, I think that standards can be helped by if they are open source. But the problem with standards is you need to have everybody agreeing on them. And the problem with having an open source standard is that sometimes you get too many variations on things. You really need somebody to enforce the rigidity of the whole
Sure.
thing, and enforce the what gets in and what gets left out. That's
If I may,
part of the problem with a lot of the standards we have in the U.S. is that there's just too much room to reinterpret everything and extend or ambiguity and so on. I think the open EHR model is excellent. However, I think it's what's deterred people from using it is it's difficult. It's complicated, but once you understand it, there's an elegance to it that's very very clear and understandable. But I think it's a lot difficult for a lot of people to approach. And you know, the issue of open source is something that you know, the open source model allows people to take a project and really understand it, analyze it, and add to it. But the key element is once they've done that is to put what they've done back into the project, fold what they've done back into the project, and that's where a lot of open source projects fail, is that they fail to have a good mechanism to capture the community input. And I think that the DHIS has done a good job of that because they've had fairly strong central control with groups who have a lot of continuity with the project for a long period of time, who work on developing it, and accept input from a lot of the different projects in different countries where they have talented programmers, and get that stuff folded back in. But there's also a really strong core of people that do that.
I agree. I think it's a great observation. In fact, as you were talking about that, it brought to mind that is probably the success indicator for OpenMRS as well. It is open source. It's in lots of different places, but it has strong institutional support through these NGOs that has specific focus. And so while there's a relatively large number of programmers, work on development, they all have this small, say 8 or 10 set of focus issues that they all work on. So it's kind of a big open source project with a small open source project focus, I guess. And that seems to be kind of what DHIS has been through too, with NGO support and stuff. It's a very similar type model, don't you think?
Yes, and they've been able to keep a lot of the original developers from the people who first developed it in South Africa, and with the strong commitment of the Norwegians, which have been pretty much continuous throughout the development. First, it was USAID, and then the Norwegians, and then Norwegians with NORAD, and then the European Union picked up support for it also. But through that, they've maintained the continuity of the developers. So they have people who had literally 10, 15 years experience with the system. And there's a great value to that they've been able to maintain that continuity with the donors. And at the same time, they branched out and they have people, there's a strong group in India, Vietnam, and other places that with strong programmers contributing to it also.
Great. Well, I've got 1,000 more questions to ask, but we are at the halfway mark already, and I do want to open it up. People can post on the live stream page on Moline.org. If you want to go to HIT Live, and then at the bottom of that page, there's a link to the live stream. There's a forum there that you can post questions on. If you join the Hangout, you can ask questions in the chat and the live chat here. And so we'll open it up to our panelists. Who wants to go first? Luciana? Joyce? Luciana's always got a bunch of questions.
Seems eager to ask a question. That's good. Hello, Joyce. Welcome to the meeting. It's nice to see you.
Okay, Luciana.
You may be done. Oh, there we go.
Now, well, I was mute before. Thank you for giving me. Probably was making a lot of noise, but since 1999, I've been working with health information at this national level. That is what we're discussing here most part of the time. I mean, information systems that are needed by the national governments in order to manage the national healthcare system, and that includes mortality data and live births data and public hospitals data. It's what we have here in Brazil. And actually here in Brazil we have a strong tradition of making this information available for free in a very easy and practical way to manage this information and aggregate the information and everything. And I have to say that a big part of my PhD was done with this public data here in Brazil. So this whole idea of having information at this level, that it is what I see in many of the WHO information systems. So the WHOIS information databases and everything. And of course this aggregated level, that I understand that it's more or less the level that the SDMX-HD was devised to collect standardized information, is very important. What's my problem now with the type of project that I've been trying to develop since more or less 2003? So it's not exactly a new project, but it's very challenging in technical terms. That is epidemiological surveillance. That is my goal here with this project. Disease control, disease surveillance is a very local issue. It's a very, of course, you always have some standardization of the protocols and guidelines and everything, but the variability of the epidemic profile is so big that even for one specific disease like dengue here in Brazil, that is a serious problem. Those national-based information systems are not very suitable. So actually it's always secondary information after the epidemics is over that is collected in those national systems for epidemiological surveillance. And this is critical for us. So how can I invent a system that collects information at the point of care, the local point of care, with the context that information requires, that is very specific of that municipality, of that small area, and still making it relevant for the higher levels of the information system. And so at this point, this very hierarchical view of the information, the information system, and how to build and how to structure information systems in such a way that is possible to keep it local but still national. I think this is the challenge that we are that we are facing, and we as epidemiologists, we face it even more acutely than more stable situations like a hospital EMR or something like that. I don't know exactly, Dr. Spohr, what's the connection of the type of projects that you were involved when you were at WHO and this type of dynamics that are very specific of disease control and surveillance for acute diseases. So if you have some ideas to share with me, I would be very grateful to listen to them. Thank you.
Yes. Well, this is a good time to bring up the next trend in computer systems is going from terminals connected to the network and the internet to mobile systems, and everything is going to be moving to smartphones, and that includes data collection as well as data presentation. And fortunately, again, to get back to DHIS, we seem to be talking about that a lot, but the DHIS system is designed so that it can be used on a standard screen as well as on a small screen on a smartphone. And there are other systems too that are capable of collecting information on smartphones. And the advantage of that is when in the specific problem of disease surveillance is you need to know about a specific disease at a specific time in a specific place, and that's very local information, as you call it, as you say. However, that information needs to be quickly communicated and aggregated and presented so that people can understand that there's an outbreak in this area at this time, and see know the extent of it. Again, the DHIS system and a lot of other systems are able to map data on maps, and then you can also put data on maps over time, and so you can watch how an outbreak progresses over time and over space and over distance. Most smartphones have location awareness built in, like a GPS system or something, so they can capture a location automatically, and of course they can capture a time of an event. And the advantage of having large communications networks available is that it's very feasible to collect tens, hundreds, thousands, hundreds of thousands, millions of data points and analyze those and look at those. And so you can look at it, you can get an early warning of an epidemic, and you can watch that evolve over space and time. And you can, and the best way to present that is on a map, and you can add a time dimension to a map too. If you look at some of the nice work that Hans Rosling has done on presenting data over time, and that's the key. That the modern information systems give you the tools you need to capture that individual local data, but capture lots of it and manage lots of it fairly easily, so that there are, I mean, not just DHIS, but if you look like at the EpiSurveyor type software, which is designed solely for small devices, you can capture GPS locations, photographs, and more specifics of information, and have that communicated immediately to a central database where it can be analyzed. And you don't have to worry about too much information, because the computer does the work on this. You don't have to do the work on this. You can get thousands of disease reports and easily display those, present those in a meaningful way. So the next step is mobile applications with connectivity, and those pieces are there. You just have to use them, and there's some good tools out there for using them. There's the the Every Surveyor that I mentioned, and also there's another, the DiMaggi people in Boston have a very nice system too that is designed where it's easy for anyone basically with a minimum amount of training to put together a disease surveillance, like in your instance, a disease surveillance application, put that on a smartphone or even a feature phone, which is a lower power version of that, where you can get somebody out in the field, can capture case information, and have that communicated quickly and easily to a central database. So that problem can be solved pretty easily. I mean, it's and because the tools are there now with the connectivity that we have and the smartphones and so on.
If I can just kind of follow up on Luciana's comment and some of the comments that you made, because the context here is that you're both physicians. She's a public health physician, and I'm just a technologist, sort of. And my question is that the application that you're both talking about right here requires what we in the Marine Corps would call boots on the ground, because you're talking about capturing specific case information by specific public health officials or researchers, somebody with that specific application. To me, looking at this from the outside, trying to look at the big picture, I'm seeing what we need to be capturing is at the point of care when that patient presents in an emergency environment or in say a mobile tent city as a disaster site or something. Those kind of physicians that you have, that kind of information is where you're going to collect the most information, the most accurate, the sooner, is it not? So it seems to me that these mobile applications, maybe they're filling a need, or maybe they're blocking resources from where we need to be going with building electronic medical record systems that can talk directly with DHIS, something like that's on the horizon for OpenMRS.
Well, yes. I mean, obviously, it's better to have the infrastructure in place, electronic medical record at the point of care, because the point of care is really is the primary source of the data. And so, if you have something at the point of care that's already in use that can capture the data and communicate the data, then you're in the best condition to get good information. And in the absence of that, you would have a more specific application and a more focused application. There's a couple of other things here, which is one of the main things. One of the other things is the idea of crowdsourcing, and doing something like what Google does with its flu alert system, where they just monitor people searching for symptoms of flu on Google search, and doing that they can track like the flu epidemic a lot more quickly and easily than the CDC does, and they're usually about a week or so ahead of the CDC's reports, which are based on actual point of care reports. But if you open up your system, and again, this is a kind of an advantage of having a more open system, you can do disease surveillance and epidemiology by crowdsourcing it. If you have people, if you give a mechanism for people to report epidemics, whether it be dengue or malaria or TB or whatever. You can kind of eliminate part of the boots on the ground problem, and the problems of not having the electronic medical record infrastructure in place, because a lot of times you just don't have that. That's
true. Yeah.
Beyond a lot of places.
Yeah, I don't want to excuse me. I don't want to miss out on giving Joyce an opportunity to ask some questions as well, and then we can go back and see what Luciana has to wrap up with that thing, because we're going to run out of time. And gosh, I didn't even get to talk about what we see the future going towards. So we're going to have you back again, Dr. Spoor, that's for sure. Joyce, do you have any questions or comments? No, come on.
No, you're happy just to listen.
Mhm.
So you work on nursing terminologies, and but you know, at least in most developing countries where I work, the nurses are primarily responsible for actually delivering most of the care, and they're really the front line at the point of care. They deliver a lot of the care as well as collect a lot of the information. And so I really think that it's crucial to have terminologies appropriate for nurses and tailored to the types of services that nurses provide. So I think what you're doing is very important. Keep working on that, because that's very good. Not everybody's able to code stuff in ICD-10. In fact, nobody's able to code stuff in ICD-10. is my contention.
Yeah.
But so I think when you work on nursing terminologies, don't just think of nursing terminology. I'm not sure what you're doing, but don't think of it just in terms of hospital nursing. Think of it in terms of outpatient nursing, and also think of it in terms of nursing where you have people like nurse practitioners who are doing diagnosis and treatment, and at the level that they're trained for in different developing countries, because that's a lot of care is delivered. You know, a lot of nurses do diagnosis and treatment. A lot of care is delivered in those environments. So, if you don't want to speak, that's fine.
No, actually, I just
Luciana will happy to speak.
As supervisor, I just need to add that actually we are working with. We're not working with ICD-10. We are working with the International Classification for Nursing Practice. Specifically, one catalog that was developed for the NHS, nurse outcomes indicators. And inside the nursing outcomes indicators, we are working only with the Barthel Index, the activities of daily living index, and so we had to expand for the instrumental activities of daily living, and that's how narrow we can go as studying terminologies and trying to map them to OpenEHR archetypes. This is what we are trying to do in her thesis, and it's been hard, terminology bindings in OpenEHR archetypes are, and especially when you need to specialize an OpenEHR archetype, it's pretty challenging. We hope we can publish her paper next year, and if somebody accepts it, of course, because multi-level modeling is still not very popular. There's only 58 papers on OpenEHR and only 2 papers on Lean, 36 papers on ISO 13606. Is still science that is building up, but I don't know why she's.
I'd be very interested in looking at your paper.
I don't know why she's shy today, because her English is improving so much. But anyway, so let me back to you, because it's only 10 minutes and we're finishing. Oh my God! And it's not about Joyce or myself.
Okay.
Okay, great. As I said, I didn't know if Luciana wanted to follow up on the issues about collecting data at the point of care and being able to convert that to something that's meaningful at a higher level, epidemiologically or something. But if you do, Luciana, you can jump in on that. As I said before, I really did want to kind of talk to Dr. Spoor, because you've seen so many changes and you've seen the rate of change increase so much over this, I guess, 30, 40 years in healthcare IT, basically. And and just recently, installing DHIS in a cloud server. So, this is quite a rate of change from the IBM Green Terminal time that you worked in, and maybe punch card time. And
I've used punch cards.
I know I did, so I'm assuming you did.
That's how old I am.
And well, I used them. So, but where do you see? You said that you see a lot of things going to mobile apps. What do you think that where do you think the big advances in interoperability lie? Because I see a huge problem with the fact that we're collecting more and more data, but the semantics are all locked up in the application and database designs, and the semantics aren't freely available to exchange about. What I mean by the semantics, in some cases you are transferring things such like the space-time semantics, but not all the ontological choices are available when that data gets someplace else it's going. And even when you're capturing the space and time semantics, you're capturing them in a format locked up into that particular application. Do you see a point in time where we're going to have more universal semantic interoperability as Web 3.0 comes around?
I think there's a great need for it. I'm not sure that it's going to happen, though. It's the problem is that I don't think people understand or place enough importance on the need for both the semantics and the metadata. And it's really an ugly world out there because people just develop stuff ad hoc, and you just see it all the time. And again, I think WHO could play a very important role here in promoting standards and interoperability, including the semantics. But I don't think I don't see them doing that, unfortunately. So we're going to be left. I'm just not hopeful that this is going to take place. I mean, I keep pushing for it, and every time every time I can, I promote standards and interoperability and metadata. Looking for international standards in places wherever I'm working, but most of the time you have the installed infrastructure, and you have the legacy systems, which is what they put in place. A lot of times it's left over from a paper system, and it's all very idiosyncratic and unique, and you try to move people towards standard nomenclature, metadata, and semantics, but it's difficult. I think we just need to keep fighting for it and working on it. It's not going to be easy, and it's not going to come just all of a sudden. But as data gets more connected, and computer systems get more connected, and people get more connected, they'll run up against these walls that are created by the lack of data standards and interoperability standards, so that they will hopefully eventually realize that they need to approach this formally. I mean, there are good tools out there, and they just need to be adopted.
Thank you.
So it's not too optimistic, I'm afraid, but
well, actually, it is. I mean,
but
at least
we're all fighting the good fight here, though. That's what we need to keep doing.
There you go. There you go. Well, at least we agree on that. I know that I've read some documents that you've been involved with writing. I must admit that your management of patient information, I skimmed over. It's a report for the World Health Organization Press that was published this year. And Dr. Spoor has also been involved in writing the President's Emergency Plan for AIDS Relief Software Inventory Report. And it was written for the Office of U.S. Global AIDS Coordinator, 2004 and 2006. did a white paper on informatics technology for use in HIV/AIDS treatment in resource-poor settings for U.S. Global AIDS Coordinator in 2005. And he wrote the Physician's Guide to Desktop Computers. And that was published in 1983 by Reston Publishing.
Ancient. Things have changed since then.
Wow, to use the term desktop computers, that
That's
was
right.
brand new.
1983 desktop computers were brand new.
Were brand new, yes. Very impressive. Very impressive. And again, I want to thank you, Dr. Spoor, for spending this time with us and giving us this little touch of your experience. And it is quite an experience, this global experience. I find so many people that they dwell in their own little world and they don't have this big picture view like you do. And I really appreciate you putting it on record, and hopefully we can have you back sometime real soon. Joycey, Luciana, you have any other questions? Real quick.
Okay, well, thank you. If you have any questions, please feel free to contact me, and I'd love to see your work too that you're doing. So if you'd like me to take a look at that, I'd love to see it.
Okay, great. And Dr. Spoor has also provided some links for the WHO Health Data Standard Interoperability information. I'll be putting that in the description under the video on YouTube. And no more questions? Joycey, last chance. Okay. All right,
Thank you.
Luciana.
It's good talking with you all.
Thank you so much again. Everyone take care. See you next Thursday. We have Dr. Deepak Kaura from the UK, and we'll be discussing health informatics in the European Union. Dr. Kaura has been heavily involved with drafting SIN 13606, now ISO 13606, and he's involved in a rewrite of it, as well as some other programs in the European Union. We look forward to seeing him next week. Everybody take care. Have a great evening.
Bye-bye.
Bye.